This was an interesting case we got to do last week. Patient came in after previously being ablated for a PVC that was unsuccessful. This time we found it at the LV Summit. Previously ablated at, I believe, just underneath the left coronary cusp with an RMT catheter. We ended up going on quite the exploration through all 4 chambers of the heart and then some. 12 lead EKG showed some interesting findings. We have a QRS axis with 2 and 3 being positive, showing an inferior origin, and 1 being just a little negative before it changes, showing it's left of midline. The precordial transition at V1 shows the right bundle branch block morphology, and the notched V1 versus a pseudo-delta. The notched V1, that little notch right there, or this pseudo-delta shows either left coronary cusp or LV summit, LCC versus LV summit origin. More about the QRS is how late the peak of it is, showing a potential epicardial origin. But that was mitigated by this W morphology in lead 1, which shows that it is more likely closer to the great coronary vein. This is an article that goes into much more explicit detail on the research they did surrounding it, but that W pattern, even in the presence of a high MDI, often shows a distal great cardiac vein origin. Here's some anatomy. This image is of the heart from kind of a anterior, like an LAO superior, LAO cranial view. This yellow dot being the true LV summit, this whole wedge indicating the entirety of it. You can see this smooth tissue here being the coronary arteries, the left main, LAD, circumflex, and you can see our 3 valves, the pulmonary valve, the aortic valve, and the mitral valve. This GCV is the extension of the CS. This is the anterior aspect of the CS, and we ended up ablating right through here and having success. Here's a graphic representation of it. This is oriented a little more counterclockwise. Aortic valve, the pulmonary valve, and mitral. You can see the left, it says left CA, so I would call that the left main, with a bifurcation indicating the summit of the LV. And this is the GCV, again, coming through. So the tools for our success, we used a DecaNav, the CS, STSF ablator, and Optrel. We first went into the distal CS and found a pre-QRS of activation of 32 milliseconds, which was pretty promising, but we ablated and there were no changes. The RVOT, we put the Optrel in, got a lot of really good points that showed very late activation. The last place we checked before going back to the CS was a retrograde approach into the LV, where we did have some pre-QRS activation, 20 milliseconds, not quite as good as our distal CS, which could also be described as the GCV, I guess. So the original case also ablated there. We ablated more with no changes to the PVC. Because he wanted to go back out into the CS GCV, he asked an interventionalist to shoot the cores. So that's the coronary artery catheter injecting dye, and you can see the left main coming down there, the LAD, and the circumflex. The bifurcation of those arteries show the summit of the LV. This is a catheter that is not an electrophysiology catheter, but it shows it where we had it. And it's going out the CS here and into the GCV, which is just the extension of the CS. The proximity, we measured the proximity of the target out here to the left main was about 10 millimeters, which reassured us that we would not be injuring the coronary artery circulation by ablating where we wanted to ablate. This is a zoomed in picture of the maps that we got. This little red donut shows the short axis of the left main. When measuring from where we wanted to ablate, and there we measured 10 millimeters. This is a zoomed out of that same picture. You can see here the views are reversed. This is an LAO, this is a AP view. The AP view, you can see that separation. This is the short axis of the aortic valve. You can see it a little more almost en face there. This is where we ablated above the valve with no success, but after coming back in here the second time, moving a little further out, these two were our first ablations. That blue dot was our earliest QRS during the PVC that we could find, activation during the QRS. And these were the points we put in after on our second attempt with success termination. So an interesting differentiation the doctor made with the tissue that we were up against. The first attempt showed an impedance of 175. When we went deeper and with no change after ablating. The second attempt showed 250, which could have shown that we ablated there already, but it also showed that tissue had changed and possibly we were deeper into the CS GCV. So after the first burn, we saw the PVC terminate. This is the propagation map with just showing the CS and the outflow track of the LV. You can see it really starting through here. There is an early-ish point here, which is what we were going after, but it wasn't as early as up there, so we ended up going here. This is more that AP view. The next slide shows the same propagation, but with the added RVOT map. If it decides to work. Okay, we do it from here.